नहीं हाथ लगाओ सर।
We are
ओके
live
सर।
now.
Yeah.
So, good evening, delegates and all the participants. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcome you all for this webinar. Today, we are back with our series Mid-Mocha Meetup Season 1, Session 7, and the topic is Adolescent Health Issues. So, it's my privilege to introduce the organizer of the webinar, Dr. Ritu Samphani ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, MRCOG. Ma'am is consultant obstetrician and gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio, infertility specialist. Ma'am is also a part of NUHS Singapore, co-founder of MAAM and board member of SWWC. So I welcome you, ma'am, and I hand over the session for you.
Yeah. Thank you. Thank you so much, Sahiti, and thank you, Shield Pharma, for constantly providing the platform for this academic series. Friends, as we all know, every week I am getting one stalwart for the discussion. So last week we had a wonderful discussion on anemia with my very dear friend, Professor Dr. Rajshri Katke. So
Thank
again,
you.
I requested, yeah. So again, I requested her that we got lot of appreciation in all the media that the session was very excellent and all the practical points are discussed. So I requested Rajeshri because Rajeshri recently presented on the adolescent health issues a prize-winning paper and prize-winning lecture also. So we thought, why not we can discuss this topic in our webinar so all can be benefited. So a very, very
Yes,
warm welcome to you once again, Dr. Rajeshri. We are
thank you
really
so
honored.
much.
We are really honored to have you with us.
Thank you. Thank you.
May I request Saiti, will you please do the introduction?
Yes, ma'am. So
Yeah.
it's my honor to introduce Dr. Rajeshri Katke, ma'am. Ma'am is the professor and head of unit OBGY, ex-superintendent of Kama and All Bless Hospitals, Mumbai. Ma'am is the renowned obstetrician and gynecologist and surgeon par excellence, medical undergraduate and the postgraduate teacher for more than 2 decades. Ma'am is the researcher, editorial, and the author, associate member of RCOG. Ma'am has more than 100 plus publications in national and international journals, 330 plus citations, 1,80,000 global reads. Ma'am has received numerous awards and appreciation, including recipient of many awards like General Secretary of United Nations, honorary
It's
Mercury
okay,
Award.
Saiti. It's okay.
Yes, ma'am.
I think it's okay.
I hand over the session to you, ma'am, and I welcome you.
Yes, yes, yes,
Yeah, yeah.
yes,
Warm welcome, dear Rajeshri. So,
yes.
friends,
Thank you
today,
so much.
yeah. So, Dr. Rajeshri will be going to share with us um the presentation on the adolescent health issues. Friends, I request to all of you, those who are joined via Zoom and via YouTube. So, whatever the questions, please feel free to write in the chat box. We have tried to make this session interactive and we can take questions in between also as per the case discussion.
Yes.
So, over to you, dear Rajeshri.
Yes, yes, yes. Thank you so much, Ritu, for the warm and kind words. So generally, what we will discuss is that there are some cases which in a practical gynecology, it becomes, a little bit of difficult in situations. So how we should go ahead with that. So she is a 15-year-old girl, comes to your clinic with her anxious mother with 2 months of amenorrhea. She is in class 10 and tensed about her exams. She weighs 70 kg and has acne. She had got her first menses at the age of 13 years and her cycles have been irregular. Her mother says that she is busy studying and always busy on her phone. Okay. So what is the clinical impression? So basically examination, we just see because she has a general examination in that, she has acne and obesity, BMI is more. So basically PCOS is one of the condition and she is having most of the, unovulatory or irregular cycles in that. So, Dr. Ritu, we should look about how to go ahead with such cases. Okay, so one is the
Yeah.
most important, the classical history of the patient. Then the examination is very important, in which we should calculate about the BMI and everything. About the investigations, we should go ahead with the simple ultrasound because here we are not doing the TVS, so it should be a good transabdominal sonography. And suppose the sonography shows the signs of the PCOS, then the diagnosis has been established. In some of the cases, we should go ahead with the even the hormones like FSH, LH, prolactin, thyroid, depending upon if she has another symptoms like hypothyroidism and all. In that, basically, how you should go ahead with that, so because and now the cases they are coming with the adolescent girls, they're directly coming with the finding it with the Google Docs, or they are coming as a PCOS and all. So
Yeah.
how to go ahead
Here,
with that?
here to
Suppose because
interrupt
they,
you, here
yes,
to
yes, yes,
interrupt you, Dr.
yes,
Rajeshri. Yes,
uh,
you have very correctly mentioned that most of the girls are coming because these days in my OPD, whenever I ask the girl that when was your last menstrual period, they tell me, ma'am, please wait, we have to check on our mobile. They have to open the app
oh
and then
yes,
they will check in this app. And then the another question when I ask them, is your menstrual cycles are regular? Only the one answer comes, ma'am, according to my app, the cycle is regular. So otherwise, sometimes if we ask that when was your last menstrual, when is your coming period is due, they will tell, "Ki, ma'am, let me check in the app. According to app, this will be on this date."
yes.
So very correctly you
So,
have pointed.
this is and the second important thing is that they get so much of the panic because of the, half information on the Google.
Yeah,
And there
yeah,
is so much of the havoc in the, because of this PCOS and all. So what
yeah,
next to do is that, so once it is being established, basically this is the hormonal imbalances. This is a lifestyle disorders type, the things in this, because she has 70 kg and all. So whatever patient they are coming
yeah,
with the PCOS to me, I always tell them that first for a month you should go and reduce the weight. That is the thing. You change your lifestyle. In the diet, all of them, most of them, they 90% they are having with the means all fried foods, pizza, burgers, and very irregular eating habits, because they don't take a complete meal in a month's time also. So that is the thing one should avoid. Whatever amount of the pills we prescribe them or we are giving them, but that is
yeah.
for the on the temporary basis, unless there is a hormonal imbalances where you can correct it off. And lifestyle changes is very important, and everybody is at the sitting place, sedentary life, at the school age also they are like a sedentary, because they are just going to the classes, coming up, and after that there is no you can
No
say that
physical activity.
no
Yeah, yeah.
physical activity, there is no outdoor sports, sports,
True, true.
that is not
Only the
there.
mobile
So
sports, only the mobile games are there.
yes, yes, mobile games are there, digital things are there, and with that, see what it happens, the in a menarche after menarche, to establish the hypothalamus pituitary ovarian axis, it takes some time to get click and regularize. And in that only, these people, they are not getting active also physically and mentally also, and that's why they have lots of the adipose tissue and the aromatization,
Yeah,
extra aromatization, and there will be most of the hyperestrogenic conditions, and there will be hyperandrogenism, and they will have acne and hirsutism, and all those things, they will be more common in that. So this is about the lifestyle changes and diet. They should do the walking exercise, or the swimming, dancing, zumba, whatever they want to do, but they should do some of
true.
the exercises, because without that there won't be this metabolism of the fat, or the loosening of fat will not be in there, apart from the diet in that. So on the medications, what I feel is that the most important thing is the change of the diet, and everything is there, and then you can go ahead with the medications like what we can say that what you suggest, Ritu, medications may.
No, no, see, here, as you suggested, related to, first, I want to add one more point, role of lifestyle, as you suggested very
Yes,
clearly, rightly also, that yes, of course, some kind of the physical exercise is very important. Besides, as what the patient class I am getting, most of them are addicted to alcohol and smoking.
yes, yes, that is
So
why I
that
was going
is,
to
yeah, yeah,
take
yeah,
that.
yeah. Yes, yes, yes. So, because that is very common in the corporate culture, every girl, once you ask the history, they tell, yes, ma'am, 4 to 5 cigarettes is the norm. Though alcohol we are taking
Smoking,
occasionally, or we are taking in the weekends, or we are going for some parties, then we are taking. But that also we have
drugs.
to emphasize. Yes.
Late night, there is no
Yes,
sleeping
late night
also. So
parties. Yes.
biological clock is, it's all being
Very true,
disturbed in
very
that.
true. Total, the pattern is totally disturbed. Na? They are sleeping at morning 3 a.m., 4 a.m. and getting awake by 2 p.m. or 3 p.m. So whenever we tell that you have to go for the exercise the morning, they're saying, मैम हमारी morning ही 2 बजे होती है, हाँ? हम दो
Very
बजे
true.
सोकर उठते
This
हैं.
is quite common nowadays,
Yeah, yeah,
and they
very
got
true,
up in 2 o'clock in that. So with the
very true.
medications, we have to see what is the deficiency
Yeah,
and whether the FSH-LH irregularity or reversal of the ratio is there. Then you can advise either in the form of the low dose combination of the pill, or sometimes if it is so much of the anovulatory cycles, and if it is associated with the prolonged amenorrhea followed by the bleeding PV, then just see that whether you can give it of the progesterone. So these
very
are the
true.
things one should. And if
Yeah,
suppose they have a high testosterone levels, acne, hirsutism is there, then we can go ahead with drospirenone and all these newer drugs they are coming up then. But the most important thing is that we should not rely on most of the hormones only, but we should go with the all lifestyle changes, de-addicting programs and all, and the stress level and androgen steroids, that it will come down with the physical activity, and definitely these girls they can regularize their cycles and all. And the most second important thing is that I have seen many of the patients, they are coming with for 6 months they are getting the hormones,
yeah,
7 months, once of a year and all. Why we should not treat them very aggressively when they are unmarried, they are at a 15 years, 16 years and all, so what we should do is that even it is going to get regularized after the if she gets married, or when the hypothalamic pituitary axis it gets settled after menarche in 2 to 3 years of that. So we should give some breathing time for them also, and we can go for the medications for that. And counseling is the very important in that, because what they ask you at the age of 12, 13, do I get a malignancy? Will won't I get a mother? I will be infertile. There will be, I have to go for IVF, or I have to go for surrogacy and all these things. So there are plenty of things in their mind in that, though they are coming with the mothers, they say that, ma'am, I want to speak you alone. And sometimes they do have they are sexually active also. So we have to be very clear in telling that about the chances of pregnancy also, because sometimes getting in our country becoming unwed mothers is also again a problematic. And sometimes if it doesn't work, then people, they are taking, most of the girls, they are going with the postcoital contraception or emergency contraception very frequently. That can also make it the irregularity of the cycle. So counseling and telling the scientific knowledge to them is very important, what I feel. So you
yeah,
would like
very
to add
practical
anything,
point. Yeah.
Ritu, in this?
Yeah, yeah. So very practical point you have added. Yes, most of the girls are coming to us with the history of intake of the so many of emergency contraceptive pills. Huh? Some are taking 3, 4, some are taking more than 6 in a month. And besides this, yes, this is very common. So we have to be very punctual and very specified to while we are taking the history from the girl. Of course, sometimes it is necessary also that we have to have a conversation with the young girl in the separately. Sometimes they
Yes,
hesitate to tell all the things in front of their mom or sisters.
parents
So
and all.
that is also very important. And
Uh,
Rajeshri, in most some patients now, I usually prefer the combination of myomicetol
yes,
and
yes,
dipyramicetol.
I agree
Okay.
with
Yeah.
that. But if they are associated with the prolonged amenorrhea, with bleeding PVA
Yeah.
and puberty menorrhagia, then you should give
Correct. Huh.
medroxyprogesterone acetate, and after
Yeah.
that you
Yeah.
can continue with the low dose. But I
Yes.
prefer with the low dose estrogen progesterone pills rather than giving into the high estrogen, because
Yes. Yes.
here I would like to tell you one example of that. One patient has referred to me around, this is a story of 4 years back, and she came with the calf tenderness, and she has a DVT just because of the large doses of the OCP. They gave the highest amount of the estrogen, more than 30 microgram in that and all that. That was the thing in that. So don't go for that.
Yes,
So
yes.
this is the second commonest. We have done a study about on the patients, and then we have come with the these practical presentations in that. So this is the one. Second commonest is the 17-year-old girl comes to you in OPD for complaints of thick curdy white discharge from vagina associated with the itching. She is accompanied by her mother. On history taking, she reveals that she has a boyfriend and she is sexually active. This is the point nowadays. Previously we used to say that, this the thick curdy white, she's coming with the candid and all. But nowadays it is very important to know that whether they have a boyfriend and whether she is sexually active and all. And they do nowadays. They tell us also. Will you inform police or just treat her for vaginal discharge and medical legal case? There was I was one of the panel moderating and all. There is a very much vast discussion on this point. So basically, with the POXO Act, under 18 years of age, if suppose though she is sexually active in that, and suppose they have some problems with her, or problems of amenorrhea, pregnancy and all, then you are supposed to, whether you are in a private setup or the government, then you are supposed to inform to the police, not for a routine things and all. So
Okay.
basically, this is just
That
to
is very
highlight in that.
yeah, yeah.
And many of
Hmm.
the gynecologists, they have agreed there also. And I have worked extensively on the committee of the POXO in a Manodharya scheme, and I know about the legalities and the boundaries of that. So it is very important in that case. Sometimes what it happens in, I will give an example.
Yeah.
Patient has come to us, and she was amenorrhea, white discharge and all. They do sonography, they go somewhere and they remain pregnant, or they take on their own abortifacient pills and all. And after that something happens and there is a police case is there. Then what it happens, they start and come to the starting point, and in that point, then it becomes very problematic for us, why we have not informed in that. So age limit and punishment for the POXO, examination of the victim of the sexual assault, if they are coming in even to your clinic also, basically take the sample collections. What if she is pregnant? So basically this is under POXO, so it comes with the legality, and then we can treat according to that. And syndromic management, we know that we are having with the MDAX, the KIT 1, KIT 2 and all. Generally, we prefer to go for the doxycycline, then metrogel, and these if antifungal tablets and all. So this everybody knows, so I am not highlighting on that. And basically, many girls, they are asking about, Dr. Ritu, is about the choice of contraception. So in that, definitely we are not going to give the intrauterine devices in that, contraceptive devices. But believe me, some of the girls, they ask the property also.
Yes, yes. So many
Yes,
girls are
that is
coming
it.
and asking. Huh.
Yes, they says ki we don't want pills, but put it the cooperative, and for 3-4 years we will free of that. So generally
Yeah.
I counsel them, no, 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 because if she develops endometritis or PID and all, so it will be very difficult. So we have to counsel them. So basically barrier or OC pills, that is the best choice of that. But third important thing is that they should know the limitation of the this also, barrier contraceptive, like a male condom. Generally female condoms nobody uses. It's very difficult to use that, and that is for the commercial sex workers mostly it is being advised in that. So these are the things about the this thing. Then
And here, the
this is about
Rajeshri, here I want to add as
yes.
you have very correctly pointed out, lot of girls are coming these days for this IUCD insertion. And
Yes.
and whenever you prescribe them for the regular contraceptive pill, that if you want to avoid, you can take the low dose pill.
Mm.
So they definitely they deny immediately. They say, no, ma'am, we are not indulging in the sex every day. So why should we take the tablet every day? Is it okay if we are taking?
Mm.
So many times I've explained them that that is not good. But still they are taking in a month 3 times, 4 times. Then their cycle is getting disturbed, getting heavy
Yes.
bleeding. Then again they
And
are approaching us. Yeah.
one thing is that one answer I have never thought of, one of the very in a corporate and celebrity like person. She asked me to put the cooperative for this thing. I said no. Take a
Huh.
pills. The answer was that I will not afford to get spoil my figure with the hormonal pills.
Oh.
So whatever it may be the remote damages, I am no way concerned with that. But at this present moment, I want to maintain the figure, so I don't want to go for the pills. Still, I said no for her. So this
Oh.
case 3 is about the puberty menorrhagia. So generally, we can discuss on the puberty menorrhagia. So basically, in puberty menorrhagia, there are the two important things is that whenever the patient is coming to us with the anovulatory cycles, you have to correct with the progesterone and all. When they in the acute bleeding phase, when it is coming, so it sometimes it is very difficult. We have one case where she was around 2 gram of the hemoglobin. We gave blood and all, and it was not stoppable also in that. So we have to give a conjugated estrogen to her and to stop the bleeding with the tranexamic acid, and then we have put with the estrogen progesterone pills in that. And we have then investigated with the bleeding disorders also. So patients, they are not responding to the hormonal line of treatment, and moreover, they are having lots of bleeding, dropping down of the hemoglobin. Then you can go with the coagulation profile also, see for any bleeding disorders or not in that. And here, what I would like to say, acute phase arrest of the bleeding with the progesterone or the high doses of the conjugated estrogen. And after that, the maintenance will be either with the monophasic pills or the triphasic pills in that. But basically, we should give with the biphasic ones or the combination of the low dose of the estrogen and the progesterone one in that. And
Correct.
in acute this thing, you can use the norethistron acetate or the medroxyprogesterone acetate around in a 20 to 30 milligram, and for 3 days, and then after that you taper down the dose and maintain on the 1 BD dose in that. So this is about this. This is a very important thing nowadays. I think this is about the vaccine. So HPV vaccine, they are coming with most of the queries about that, and most of the people, they are having the awareness. So generally they ask whether to take a bivalent or quadrivalent. So we always give protection with the, because HPV 16, 18, 31, 33 and all those things. So this is the one thing is that we can conceal and tell them to take in that. So I have a brief presentation about some of the ovarian tumors. So I'll just brush it off, because
Yes,
this is
yes.
the only thing which will have in the this thing. So malignant neoplasm are the fifth most commonest cause of death among the 0 to 18 years. We are getting these gynecological malignancies, including the ovarian, uterine, cervical, vaginal, and the vulval cancers, have been well described in the general population. So generally, these are the things where in the adolescent girls, what you have is that germ cell tumor, epithelial, sex cord stromal tumor, sarcoma, and other tumors. Okay. So in the uterine, you will get a sarcoma or the germ cell tumors or the clear carcinoma. Then in the cervical part also, you will get either adenocarcinoma or the squamous cell carcinoma. And in general, for the vulva, you will get the sarcoma, melanoma, squamous cell carcinoma, and germ cell tumor. So basically, 87% they will have ovarian malignancy. Vaginal cancers around 4% of that, cervical around 3.9, and the uterine cancer they are 2.5%. So this is the one of the statistic. Though we are not getting patients, but nowadays we are getting adolescent with the tumors, ovarian tumors in that. So generally, I have just highlighted about the breast cancer in adolescent girls. So basically, if they have a BRCA1, 2 known family history, which is very important in that. But the adolescent health providers play a critical role in educating the adolescents and families about the health behaviors related to cancer prevention. Cancer prevention is very important in adolescent girls. Therefore, sometimes because of the changing, health behavior, obesity, or the family history is there, BRCA1, BRCA2, mutations. So generally, they should come with the early detection of all these cases with the screening of the cell breast examination, or if they are having the breast tumors, go for the mammography. That is the best technique in that. So basically, why the adolescent girls with the CA breast is having the challenging thing is that you have to look for the whether they are the HER2 positive, receptor positive breast cancer. then you can go with the adjuvant paclitaxel, this chemotherapy. And for the HER2 negative breast cancer, then new adjuvant chemotherapy. So basically, in this, what we would like to have is that we should go for the breast conserving surgeries with the adjuvant new chemotherapies. So that is for the breast. Cervical cancer, we have a HPV association. I just spoke to you because 16, 18, they have 70% of the precancerous lesions in that. We know all the things at early age, at marriage, early sexual activity, multiple sexual partners, smoking, malnutrition, use of OC pills, lack of awareness. These are the things which leads to the CS cervix. So health behaviors is one of the very important, problem in that. So in a behaviors include the smoking, alcohol, not having the fruits, vegetables. So these are the things in that. So demographic and developmental information of the family, breast cancer history and the experience. Psychological factors, they are very important. So nowadays they go with the behavioral assessment system for the children. So this is also very important with the family and all. So then comes with the gynecological tumors. Gynecological tumors, basically we have seen about the breast, CA, cervix and all, but the most 67% is that of the ovarian tumors. In that, we are having a juvenile granulosa and theca cell tumor and the stromal ovarian carcinoma, very rare in the children, but still we are getting some of the cases of juvenile granulosa cell tumors in that. So this is the some of the tumors, in adolescent we have been I have been reported in that case. She was a case where 14-year-old with a huge mass in that, and it was a solid. There was tumor markers were raised, so we opted it with the laparotomy approach, and it was around 5 kgs, but it has not been a malignant, but it has come as a borderline one. Is that? So that is the thing. Then comes to the mature teratoma or the dermoid. Dermoid is very common. Everybody is having in that. So you should look for the whether it is a mature or the immature teratoma. Immature teratoma, they are more having the with the malignant variant and than the mature teratoma. So these are the things. So whenever such patients they are coming to you, then we have to see for the everything for the ultrasound required. If it is, go for the CT scan. See, this I would like to tell you, this is a very good case of, she has an adherent teratoma in a young girl, a case report with the review of literature. I will tell you the brief history of that. This patient has been operated in a remote place for the dermoid, teratoma. They could not able to take it out the teratoma. They have not, because it was very fixed and they have not understood it was a malignant. And the scar was given from this to this, right up to the zipisternum to the lower pubic hairline. And after that, she has developed a huge mass in that. And she came to me, and it was everything, it was stuck to the bony. She was very cachexic, very breathless and all. And I operated on her, and we have removed around 7 kgs adherent teratoma in that with me. Dr. Sharad Bansali was there, the oncosurgeon. We both operated in her. So basically, these such sort of the tumors, that it becomes very difficult whenever you see that the tumor is very solid, it has a malignant appearance, or there is a spreading of the tumor into the abdominal cavity. Then don't take it out the piecemeal, just take a part of that, see for the frozen section. If it is a malignant, then take with the either help of the oncologist, and then you should go ahead for the treatment. Then comes to the Sertoli Leydig cell tumor. It is a rare stromal tumor which is having a serum alpha fetoprotein levels. Dysgermina is the most frequent ovarian malignancy GCT observed during the adolescence. So everybody has seen the dysgerminoma cases. So most of the cases they are having is high levels of the HDH or the SCG levels in that. These tumors, they are highly radio sensitive, but in early stages disease, surgery alone is a curative. So this is about the dysgerminoma. Then we are having the teratomas, mature, immature, epithelial malignancy, stromal tumors, Sertoli Leydig these are the tumors which is common in that. York sac tumor is the most common malignant entity in young population. See, I have seen only 2-3 cases of that, but they are very highly malignant and they are radio resistant also, and they will having a peritoneal metastasis and lymphatic spreads are usually observed in such cases, and there will be a, if suppose if you don't do the conservative surgery and chemotherapy, then there is a spread will be more in this, and we have to look for the in all young girls, you should go for the conservative surgery in that. Embryonal carcinoma. So this is also a highly malignant tumor, but you can say we have seen more in children than the, adolescent group in that. So this is a very nice thing how to go about the, model of care in adolescent girls. Education of primary health care for reducing the referral time to the oncologist. Optimization the clinical environment and dedicated. Then psychological support should be given to the family and all while treating them. Then these are the after enrollment multidisciplinary tumor board is very important in that, because in adolescent girls the whole life is there, her work performance will be there, then mortality and morbidity. So we have to go with all this model of the care, all national and international level, all of them they are following with the this model of care only. So specific gynecological concerns. See, this program has a very short time, so I am in a hurry to finish it off fast. So specific gynecological concern is that in a these young girls, we should have a fertility sparing surgery should be chosen. So moreover, pelvic radiotherapy may cause the ovarian insufficiency with subsequent infertility. We are supposed to give the correction with the surgical and then minimal amount of the then required amount of the careful radiotherapy, mainly in a CS cervical, and chemotherapy in the ovarian cases in that. A multidisciplinary team of care for the adolescent young girls with the gynecological tumor should include also oncofertility experts and endocrinologists and periodontologists that may ensure that the patients and exact management of the gynecologic issue during and at the end of the treatment, such as the primary ovarian insufficiency in that. So the loss of ovarian function subsequent to the gonadal toxic therapy because of the chemo or the radiotherapy, it can give rise to a multiple health risks like a cardiovascular, osteopenia, osteoporosis, and all like that. GnRH analog reduces the gonadotropin levels, placing the ovarian in an artificial prepubertal state. Fertility preservation and the future pregnancy outcomes. AMH level useful marker for the assessing the ovarian reserves in that. So this is about the, I have already explained to you for the fertility sparing surgeries in a cervical cancer, 1A, 1 and all. We are all knowing that for the cervix, we are doing the conization, leads or the such things, whenever there is a early stages of the diseases are there. The second important thing, now the whole world is looking with the cryopreservation techniques, in that to maintain the high ovarian reserve in the women younger than 40 years, or these patients undergo for the cryopreservation for the cortical ovarian tissue. Cortical ovarian tissue it should not be a malignant one. So we have to see for that, for the cryopreservation of the oocyte, either oocyte retrieval after giving the GnRH analog and preserving the ovarian function for the future fertility is very important in that. Sometimes we have to, if both the ovaries they have been developed in that, then if you are taking both the ovaries, keep the uterus even for the embryo transfer in that. This is the one thing we should know, is that what is the preventive surgery. Some of the people, they inherit the gene mutations that make them very likely to get certain kinds of the cancer at an early stage. So in such cases, some people and their doctors might decide on surgery to remove the organ before cancer has been. We know the Hollywood actress, she has removed her breast. I don't want to take the name of that. This is called as a preventive surgery, means prevention of the cancerous in that organ. Before that only they can take it out. Suppose in some of the families, they are BRCA1, BRCA2 positive. The mother or the sister, they are having the CA breast and there is a potential chances of having the malignancy to them, they can do the preventive surgeries in that. Then the late psychological and psychosocial effects of the gynecological cancers. So basically limiting the lifestyle related and the environmental risk factors, no smoking, limiting time spent in the sun and avoiding the tanning saloons, then HPV awareness and avoiding all the means to go for the safer sex practices and HPV vaccination, healthy diet, nutrition, exercise, these are the things. And vaccines to help to prevent the cancer that we have spoken in that. So the vulval tumors, it is rare in the children, but we do get some of the cases just to include the presentation. So vaginal and the cervical tumors we have been explained in that. We have one case of rhabdomyosarcoma. I have seen also that patient is died, but she was not adolescent. She was around 18 to 20 years, and she has extensive polypoidal mass was there. She was pregnant and she died because of that. So uterine tumors, we know that rarely they might have with the sarcomatous or the leiomyosarcoma in that. So these are the gynecological tumors. One should look for that. So I would like to end my talk with that healing takes courage. And we all have courage, even if we have to dig a little to find it. Definitely. So one should have, there is a long treatment with the long diseases. We have to be very careful, very courageous. As a doctor, we should be very compassionate and we should offer all the best treatments to them. So thank you very much for listening very patiently. This program has only half an hour of the time, but I took a little bit of more time out of it, I think. That is the thing. So I'll just
No
stop share
problem.
and
Yeah.
so that is the thing.
Yeah.
So this is
Very nice.
my in the
Very nice.
adolescent. So because why I included the tumors also, because I have seen the tumors also in adolescent, because I had been doing since last 20 years of the malignancy or the difficult gynecological tumors and cases, they are coming to me. So though in practice some of the girls, if they are coming to you, at least you can refer to them at a right place. That was my
Very
motive.
true. Yeah, very true. Very
Mm.
nicely you have presented, Dr. Rajeshri. You have covered
Thank
all
you
the
so much.
points. Dr. Rajeshri, one question, as you have very nicely shown about this dermoid also.
Mm.
So, is it like that if the patient with the big dermoid cyst, with the her MRI report of age 15 years or 16 years coming alone or along with
Yes.
the boyfriend, still is it required to inform the police according to POSCO Act or no?
Yes, yes. Because if
Okay.
suppose they are coming with you, and even for the sake of the responsibility, who will take the responsibility of her operation? So her parents, at least if she is coming with the parents, that is very good. If she is not coming up in surgery, if suppose she dies or something happens, so how we will be responsible for that? So it is
Okay.
very important to inform that, because to give the consent, she is not a state in to give a consent because she is minor.
Yeah,
So according to the law, to give the consent for anything, it has to be either their guardians or there has to be their legal guardians.
very true.
And
Very true.
most of the times what it happens, I'll tell you, very nice example. I means couple of times I have given. There was one patient come to us, and we this everything they have hide the history. Generally they don't tell and all those things and all. After
Mhm.
that we terminated it. There was a Saturday Sunday, so the abortus was kept, and after on the Monday morning the police came. And they said,
Acha.
"Ma'am, we want a abortus." And all. I said, "Which case?" So this and this case. And so because they do their investigations also. So how we can explain if suppose we don't inform to them in such conditions, it is likely that we are not following the law of the land. That is one thing. And suppose we are very good, our aim is to help the patient, but basically at the same time they also turn down, na. Their
True.
parents, they come and they says, "Ma'am, हमको we want to do a police case on that boy and everything."
Mhm.
So why not to inform? So you should be safe.
Very good.
Or take
Very
a
good. Okay.
consent of
Yeah.
the parents and keep it with you.
Yeah. Thank you.
Mm.
Thank you so much.
Because
Means
in a
this
court,
is
it is very difficult to answer in that. Though we are in a good faith, we do many of the things. But if they are minor, then these are the things we should practice.
Very true, very true.
Mm.
Another query, as you had operated lot of patients of this dermoid, so is it like that you have to track on the follow-up for post the dermoid surgery? Uh,
Yes, yes,
according
yes.
to
We
your
have to go.
clinical experience, you suggest that have you seen the recurrence of dermoid also in some patients?
Yes, yes, I have seen recurrence of the dermoid also, and most of the times, if they get rupture, then it becomes very difficult, spoil. Isliye on the laparoscopy also, if you are taking it out, don't get
Yeah,
rupture and all the material, take in a endo bag or put it in the
yeah,
POD and take it out from there. So that
yeah.
is what the things. I must have removed the dermoid around, not in adolescent, but little bit of higher age of that, around 4-5 kg dermoid. It was like that.
Okay, okay,
And big,
okay.
big tissues. I mean, there is a spine and all those things
Uh,
and bones and all. It becomes very difficult in that if suppose that spicule goes and this thing, but these are the rare cases. But in a normal, you can take it out without spilling through the laparoscopy also in that,
true,
but
true,
with the
true.
endo bag.
Yes,
But
yes,
do a
yes,
tumor markers in adolescent girls because
yes.
most of the times we don't do and we do blindly all these things. Look at that girl of teratoma 7 kg. We operated on her, but she
Hmm.
has been left like that, and she was nobody has looked up. She came from a very remote place, and after that it was spreaded everywhere. It was like stuck to the bones and all.
Luckily, she has came to you. Great.
No, no,
God
that
is
was the
great.
luckily, yeah, and God is great. Really,
Yeah,
nobody has touched her. Even I was feeling wow, what to do for her, but she was breathless. I said, "ठीक है, let me take it out and we can do." Because in this case, at a secondary, the R0 surgery was not possible. We could took it out and we gave a chemotherapy for her. She was
true, true,
better there.
true, true.
And always put whatever you remove it, please send it to the histopathology. Most of the
Yes.
times it has not been sent to the histopathology. I understand in a cities people they do it, or in a I don't know, but but histopathology is very very important. We don't know the status of that. The final diagnosis is with the histopathology. That is the thing. And second thing is that whenever we have put a scope in that or open the case, and we feel that this is looking as the abnormal, solid elements are there, papillary projections are there, multiple septations are there, or there is you feel that the look is not good in that, or there is a hemorrhages on the surface, then don't spill it, don't touch it, just take an opinion, or take a biopsy and see whether it is a malignant or the benign one. This is not for the 90% of the cases, but suppose in a 10% of the cases, if it happens for one patient also, for one patient, for us, that is a 1%, but for that patient, that is a complete life of us. So we
True,
should
true.
think
So
of
it's
that.
much better. It's much better
Much
to be
better.
on the safer
Always,
side for
always
the
a
patient.
practice
It's fine for us
clinically based.
also.
Clinically
For-
based evidence practices. We should offer whatever it may be in some of the cases. We should take an opinion or completely diagnose it and treat it. It doesn't matter, no? You may require a second sitting for that. But if it is helping to the patient as a qualitatively morbidity or the work performance, life quality, life expectancy, then we should do all these things in this.
True, 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 true. So thank you once again, dear Rajeshri, for
Yes, thank you
explaining in
so
such
much.
great details. Thank you. Dr.
I think
Shabina has written the nice
I think
comment.
Dr.
Thank
Vijay Kalyankar, he's a professor. I'm seeing the name, but I don't know if he's the same one.
you. Okay,
Yes, I
okay,
think, and many of them, Rupali is
okay,
there, Dr. Rupali Jain and all.
Yeah,
okay,
I'm
So,
okay.
attending. I'm attending.
Hare, namaskar, sir. Good
Namaste,
Uh-huh.
namaste.
evening. So, sir is professor,
Acha,
and
okay, okay.
he
Welcome,
is
welcome,
very
sir.
good teacher and all.
Welcome, Vijay. Welcome, Vijay, sir. Huh.
Yeah,
Yes,
Dr.
all
Ritu
that.
Namaskar. I am at GMC Aurangabad. We are
GMC
batchmates.
Aurangabad.
Okay, okay. Namaskar,
Yes.
namaskar, sir. Namaskar.
Uh,
Huh.
Thank you.
So
Thank you.
that was the thing. So I was just thinking, adding like a vaginitis, puberty, menorrhagia, like this and like that. So I just included in there. my
नहीं,
this thing.
that's great, na? Actually,
This was a
we
talk. Ritu has been appreciated into the in MOX presidential webinars, the first webinars we started. I was a convener for that. Dr. Suvarna Khadilkar was the MOX president, and there was national and international faculties. So most of the international also they liked it.
Yes, that's very good,
Yes,
na? Because we have to touch on the basic points only. So, what are the rules,
yes,
regulation, and how we can diagnose? What are the recent modalities? So, we have to focus on that only. So, I
perfectly,
am not
perfectly.
seeing any questions,
Great.
not in there. So, with this, we can wind off. So,
Yes.
thank you once again, dear
Ritu ma'am, shall I
Rajeshri.
display the
Yeah, no.
certificate? ma'am?
Yes, please.
अरे
Yes,
नहीं,
please.
नहीं,
Thank
certificate
you,
is definitely.
Saiti. Thank you. Thank you.
Thank you, Saiti. Thank you all
Thank you,
the
ma'am.
this thing
Uh,
attendees, the doctors and
uh,
all. Thank you, Ritu, for inviting me. This is
it's
the
my
second
pleasure.
time, it-
It's
and
my
I'm so
pleasure.
happy. You,
Thank you.
I must admire, the amount of effort to you take from the all the your practice to share the knowledge. It's really great. It's really great. Wonderful.
जैसे
Thank
दोस्त
you,
साथ में हो
Saiti.
तो
Thank you,
हो
Shil.
जाता है, हाँ,
Hmm.
तुम्हारे
Thank you.
जैसे दोस्त साथ में हो तो हो जाता है ना?
God's
So
grace, God's grace.
yeah.
Yes.
So thank you once again, friends. Thank you, Sahiti. Thank you, Shilpama, and thank you all dear friends who have
Thank you.
joined. So I will keep on posting the regular updates for the upcoming webinars. So do
Very
join with us.
nice message, Ritu. Shabina Ima thank you, Dr. Ashri and Dr. Ritu. Very informative. Thank
Yeah.
you, Ji. Shabina.
Thank you.
Yes, yes.
Thank you, Dr. Shabina, for joining. Chalo, with this, we will wind up.